Welcome. In this presentation, I'll walk you through a lifecycle approach to complex implant care, starting with surgical foundation in the atrophic maxilla, moving into prevention through maintenance and patient compliance, and finally covering intervention when peri-implant disease occurs. The main message is simple: long-term implant survival is not secured on the day of surgery alone. It's built through a seamless transition from precise surgical execution to structured supportive therapy and, when needed, timely surgical treatment of peri-implantitis. We'll begin with the surgical phase, focusing on one-stage sinus lift strategies. Then we'll connect that to maintenance behavior and risk. And finally, we'll review a practical surgical protocol for peri-implantitis and the clinical outcomes that can be achieved. Let's start with the evidence that supports lifecycle management. First, from the surgical perspective, the survival rate reported here is 94.3%, even in challenging cases, such as one-stage sinus lifts in severely atrophic maxillae with less than 4 mm of residual bone. This tells us that, with appropriate technique, the surgical foundation can be highly predictable. Second, we see a physiological response, a mean sinus membrane thickening of about 0.70 mm after surgery. This is important because not every radiographic change is pathology. Some changes reflect normal healing and defense. Third is the maintenance imperative. Disease rates rise dramatically when maintenance is irregular. In the data shown, irregular compliers demonstrate substantially higher disease prevalence compared with patients who attend regularly. And finally, intervention can be effective. After surgical treatment, bleeding on probing drops to 15.6% at 18 months, showing that active inflammation can be significantly reduced. So the bottom line is this: successful implantology is not defined only by osseointegration. Long-term supportive therapy and patient adherence are central to survival. Now we challenge a common assumption: when residual bone height, RBH, is under 4 mm, is a two-stage approach mandatory? Here, the study includes 74 implants in 45 patients, with a mean follow-up of around 4 years and 5 months. The comparison is between Group A, RBH less than 4 mm, and Group B, RBH 4 mm or greater. The survival rates are 94.3% versus 97.4%, and importantly, the difference is not statistically significant, with a p-value of 0.459. Clinically, that suggests one-stage sinus floor elevation can be a reliable option, even in severely compromised maxillae, provided that primary stability is carefully managed. One key concept here is bone condensation and stability management. When you can secure stability, one-stage therapy remains viable, even at the limits of bone availability. Let's translate that into a practical technical protocol for minimizing trauma in one-stage surgery. First is the small window strategy. By limiting the bony window to an oval shape, approximately 10 by 15 mm, we can reduce periosteal stripping and preserve blood supply, both crucial for healing. Second is the use of piezoelectric surgery. Piezo instruments can reduce the risk of membrane perforation because they cut mineralized tissue selectively. In the study referenced here, the perforation rate achieved was 5.4%. Which is favorable for this level of difficulty. Third is dual-layer protection. After elevation, applying a resorbable membrane combined with autologous fibrin, such as CGF, can protect the Schneiderian membrane and support stable healing. On the right, you can see the sequence: window formation, exposure, and then elevation. The goal throughout is precision with minimal trauma, because soft tissue integrity inside the sinus is critical to both short-term healing and long-term function. Next, we look closely at what happens to the sinus membrane after surgery. This analysis includes 54 sites in 30 patients, comparing CBCT measurements before surgery and at an average of 7.6 months postoperative. The results show preoperative mean membrane thickness, 1.54 plus or minus 1.33 mm. Postoperative mean thickness, 2.27 plus or minus 1.50 mm. That's a mean increase of about plus 0.70 mm, and it's statistically significant with p less than 0.01. How should we interpret this? The key point is that membrane thickening is often a physiological defense response to surgical stimulus. In this dataset, thickening was observed in about 60% of sites. So clinically, we should avoid overdiagnosing infection based purely on thickening. Instead, we interpret CBCT changes alongside symptoms, clinical findings, and the patient's overall healing course. This slide illustrates a case study, management and healing of a membrane perforation. The event is an intraoperative perforation of approximately 4 mm. Instead of abandoning the procedure, the site was repaired using a dual-layer technique. The response was immediate. On early postoperative CBCT, there was marked membrane thickening, greater than 15 mm. That can look alarming. But the key is the clinical course. Over time, the outcome was favorable. The inflammation resolved, and the thickness returned toward baseline. At 3 years, the implant achieved successful loading. The clinical lesson here is the value of observation and follow-up with CBCT and clinical evaluation. A perforation does not automatically require abandoning the plan if it is repaired appropriately and monitored carefully. The focus should be on membrane protection, stable graft containment, and structured postoperative surveillance. Now we examine whether the choice of graft material affects mucosal health. The chart compares changes in membrane thickness across 3 groups: autologous bone, with an average thickening of plus 0.95 mm, artificial bone, with plus 0.43 mm, and no graft, with plus 0.55 mm. The p-value is 0.45, meaning there is no statistically significant difference among the groups. The takeaway is practical. Within the clinical context shown here, the physiological response of the sinus membrane does not appear to depend strongly on the graft material selected. This gives us flexibility, allowing graft choice to be guided by other priorities such as defect morphology, handling properties, availability, and patient factors, rather than fear of mucosal reaction alone. Now we shift from surgery to the long game, maintenance. This analysis includes 134 patients and 388 implants, followed for more than 3 years after treatment. The difference between regular and irregular compliance is striking. Regular compliers, defined here as at least 4 visits over 2 years, show a disease rate of 35.5%. Irregular compliers, fewer than 4 visits over 2 years, show a disease rate of 62.7%. This difference is highly significant, with p less than 0.001. In other words, lack of compliance nearly doubles the prevalence of peri-implantitis. This is a critical point for clinical systems. Even excellent surgery cannot compensate for neglected supportive therapy. Maintenance isn't optional. It's the primary defense for longevity. To prioritize prevention, we need to quantify risk. This slide shows a hierarchy of danger based on logistic regression, odds ratios for bone loss. The strongest predictor is peri-implant mucositis, with an odds ratio of 4.82. That means mucositis is not minor, it is the gateway to progression and bone loss. Second is a history of peri-implantitis, with an odds ratio of 4.29. Past periodontal disease strongly influences future implant health. Third is lack of regular maintenance, with an odds ratio of 3.05. The absence of professional oversight substantially increases risk. Clinically, this tells us where to focus: detect mucositis early, treat it aggressively, and structure recall intervals, especially in patients with periodontal history. This is the perfect storm model: periodontitis combined with noncompliance. The matrix shows disease risk across 4 groups. For patients with no periodontal history, regular compliance corresponds to 26.2% risk. Irregular compliance rises to 49.3%. For patients with a history of periodontitis, even with regular maintenance, risk is 58.7%. With irregular compliance, risk climbs to 78%. So 2 messages emerge. First, periodontitis history elevates risk substantially, even when patients attend maintenance. Second, irregular maintenance amplifies that risk dramatically. The call to action is clear: Patients with a history of periodontitis require a strictly enforced, high-frequency recall schedule, combined with proactive control of mucositis and plaque-related inflammation. When prevention fails, we move into intervention, specifically, surgical treatment of peri-implantitis. Here is the protocol presented. 1. Full-thickness flap reflection to gain direct access. 2. Mechanical debridement using steel curettes to remove granulation and biofilm. 3. Surface decontamination, using diamond burrs along with 0.2% chlorhexidine to reduce surface contamination. 4. Guided bone regeneration, or GBR, using a resorbable membrane to support defect fill and stabilization. The study parameters here include 15 patients and 32 implant sites, with an 18-month follow-up. The key concept is that successful intervention is systematic: access, debridement, decontamination, then regeneration, performed in a controlled and reproducible sequence. Now we look at the clinical outcomes at 18 months after surgical intervention. First, probing pocket depth, or PPD, decreases from 6.3 mm to 4.2 mm, a mean reduction of 1.5 mm. That indicates improved pocket control and reduced inflammatory burden. Second, clinical attachment level, or CAL, shows an improvement, reported here as a gain of 2.3 mm, reflecting better soft tissue stability and reattachment or maturation of the peri-implant tissues. Third, bleeding on probing, or BOP, falls dramatically, from 100% down to 15.6%. This is one of the most powerful indicators that active inflammation has been controlled. The conclusion is straightforward: surgical debridement combined with GBR can produce statistically significant clinical improvements and can halt disease progression, especially when followed by strict supportive therapy. This slide summarizes the clinical consensus as rules for total care, across 3 phases. Phase 1. Surgery. Do not automatically rule out one-stage sinus lifts even when RBH is under 4 mm. Case selection and stability are key. Use piezoelectric surgery to minimize perforation risk. Expect postoperative mucosal thickening in the range of roughly 0.7 to 1.5 mm, and do not mistake this physiologic change for infection. Phase 2. Prevention. Flag patients with a history of periodontitis. Risk is substantially higher, with an odds ratio around 4.29. Treat peri-implant mucositis aggressively and immediately upon detection, because mucositis is the strongest predictor of progression, with an odds ratio around 4.82. Enforce recall intervals. The safety threshold shown here is at least 4 visits in 2 years. In many higher-risk patients, more frequent recalls are appropriate. Phase 3. Intervention. If prevention fails, surgical access and debridement can effectively reduce pocket depth and bleeding on probing, especially when combined with decontamination and regenerative techniques. In short, plan for the full life cycle. Surgery begins the story, but maintenance and timely intervention determine the ending. I'll close with the key message. Implant survival is not a static event achieved at surgery. It is a dynamic process maintained through vigilance. From careful handling of the sinus membrane, to disciplined supportive therapy, to the frequency of recall visits, total patient care requires a seamless transition from surgical precision to lifelong maintenance. Thank you.